Good morning, everybody. And I so wish I could be there. This is the first time we've actually had a live meeting with Chess since the pandemic. And if I could have been, I would have been there. Chess and the organizers, of course, Joan, Janet, everybody do such a great job. And I want to start out by thanking them because I know on a day-to-day basis, in my clinic and from speaking with you, many of you reach out to me via email and so on, that this bringing together of folks with ultra rare bleeding disorders is so important, not just so that you can meet each other, but that you can bring your experience and share with each other what works for you. And that's the part I'm going to miss the most, is that I know in those times that you get together and network with each other, you share really important remedies that you've developed at home, tools to help control bleeding, what to avoid, what to do. And I, as a physician, learned so much. So I'm asking the folks at Chess to take good notes and let me know all the wonderful things that you all have come up with and are willing to share with us. I'll just say in the beginning, I don't think we've ever done one of these talks where we've completely finished. So it's really important, if you have questions, to go ahead and shout it out, or you can ask me to stop or slow down and answer some questions as we go. Because sometimes we maybe it's because we ask the questions during the time that we never get to the end. But if someone could keep track of the chat box or of questions coming in, I'll really try hard to stop right at an hour so that we'll still have time for discussion. And I won't feel like I'm so missing on the action over here. So welcome, everybody. And I'll go ahead and get started. I'm going to jump between a couple of different presentations because we're really changing the way that we're teaching about the clotting system. So there's a lot of new stuff that I'm going to present today that I hope will make your understanding of how the clotting system works. And why is it important for you to know that, even though you only have one piece of your variant or the thing that's causing you to have a bleeding disorder from a rare genetic syndrome? It's part of a chain of reactions that occur that starts with no clot and ends up with a clot. And so your one link in that chain, once it gets broken, the end result will be bleeding. Mild, moderate, severe, may depend on the circumstance. But I think it's really important if you understand the whole, the larger picture of how those bleeding syndromes happen. Now, hold on, I'm just trying to advance my slides here and see why it's not advancing. Oh, I guess I'm going to have to use the arrow. I wanted to put this up because one of the take-home messages I'd like you all to have is that this old model of rare inherited factor deficiencies is beginning to crumble a little bit. Now, certainly for monogenic rare disease, the concept of having a carrier parent and a carrier mother is absolutely true. When the abnormal gene, which is represented in red, when the father gives one abnormal, the mother brings one abnormal, then in general, for autosomal recessive disease, you have a child with severe disease. If the child inherits only one of these genes in red, then they're considered carriers like their parents. And then, of course, there is a normal gene in each parent as well. And it's possible that you can go ahead and inherit two normal genes, and so you have a normal child. And I say this is crumbling a little bit, is that now that we're doing sequencing, which in large part was initiated and started by Chess, they began bringing together families with rare disorders, just as you have today. In past meetings, when I and our team have been able to come, we drew blood from people, and we've been sequencing the rare genes, factor 7 and Glanzmann's is where we started initially. But in doing that, we realized that when certainly the children had the most severe form of the disease would fit this pattern. But we also found significant bleeding problems in the carriers. So I'd like you to start thinking about the idea, and many of you sitting in the audience who are parents may say, mothers in particular, heavy, heavy periods, men bleeding in the stool, bleeding in the urine, both having a lot of bleeding with dental extraction and so on, much more than normal. So carriers can have bleeding as well. It may be in the mild to moderate range, but we no longer think of them as asymptomatic. So, and sometimes the patients that we're working up end up being heterozygous. That is to say, like a carrier, they have one normal gene and one abnormal one. The thing that we're changing our thinking about in genetics is that each of those genes is controlled by a number of factors upstream from the gene that can influence whether the mutant gene dominates or the healthy gene dominates. And if for some reason you've inherited a tendency for the mutant to dominate, then you're going to look more like a patient with disease. You may be a heterozygote, that is to say you have one normal gene, one abnormal, and the normal gene dominates, and you don't have as much bleeding. Understanding what we call those upstream regulators are where we're focusing our emphasis right now. So just because you have only one abnormal mutant gene doesn't mean that you're spared a bleeding disorder. And so we're finding close to 75% of the patients that we're sequencing are heterozygotes. They aren't autosomal dominant. Now, clearly we have many, many individuals that are have both genes and they have very severe disease. But I'd like you to leave this meeting with that concept that you can have one abnormal gene, or your child may have one abnormal gene and still have a bleeding tendency. Now, this looks a little bit like the old clotting cascade that many of you may have seen, or you may have seen on the internet. It's what we taught in medical school for many years, and we still utilize this to some extent. When we talk about an APTT, you may have gone to the lab and had both an APTT and a protime drawn. PT stands for protime. This is partial thromboplastin time. Easier to say PTT, easier to say protime. These different pathways were created by research in the past, and actually at the turn of the 19th century, mid-19th century as well, to identify what protein may be missing. It is not exactly reflective of whether you're going to bleed or not. So some of the folks, for example, with factor 12 deficiency, and for some reason they went with Roman numerals, which is currently the bane of our existence because few people really understand Roman numerals anymore. But factor 12 up here, the XII, let's see, where's my arrow? Right up here. If you're missing factor 12, the PTT will never stop. It's greater than 200 seconds. It is because one factor 12 stimulates one factor, 1,000 factor 11s, one factor 11 stimulates 1,000 factor 9s. And so this is kind of like a chain letter. It's not like a domino effect. So it grows and grows and grows. And I'm going to show you a better representation of this. But in fact, people with factor 12 deficiency don't bleed in real life. In fact, the major role of factor 12 is to stimulate what we call the kininogen system, bradykinin system, which is very important ultimately in clot breakdown. So people with the longest PTT actually have a really high risk of thrombosis, of having too many clots. So the actual length of time of the PTT or the protime does not correlate with your risk of bleeding. And so children who are newborns, healthy newborns, many of them are missing, they have not missing, but they're born with low levels of factor 7, low levels of factor 9. And 11. And in fact, their PTTs are very, very long. The pro time is long, but they have a tendency tenfold likelihood of developing thrombosis than an older child. If you think about it, that makes sense. You don't want to have a child at risk of bleeding at birth. So we'll talk a little bit about how it is and why. I like this slide, though, which was prepared by Dr. Pruthi at Mayo Clinic. Many of you may have him as your doctor. He's a really smart, super good hematologist. And what he put on this clotting cascade is something I think is very helpful. And what this shows is what the frequency is of these carrier states or deficiencies. So factor 8, you see 1 in 5,000 people with a mutation of factor 8. Factor 9, 1 in 30,000. And of course, if you're a boy, this is on the X chromosome. So if you have one mutant, you have the disease because you don't have another gene to back you up because it's on the X chromosome. But for factor 11, we find a very high carrier state in the community. It's one of our more common ones, and that's as compared to factor 7 deficiency, and one in 500,000. Down here for factor 5, 10, and 2, it gets even more rare. Very, very uncommon to find these cases. And it's hard to even say whether it's 1 in 2 million or more because we just haven't done a good job of identifying them. And fibrinogen, they've only really described greater than 150 cases. Now that we're doing more sequencing, Chess started this trend, and now if any of you are in HTCs where they have an Athens study open called Athens 10, we're sequencing all of these proteins, and we're finding more and more of them are around. So, but I think this is a nice example. Von Willebrand's disease, who I don't believe folks with von Willebrand's are in this particular symposium today, but the frequency is about 1 in 100. So give me a minute, guys, because this is going to be really important. Hold on. This is the new way that we're teaching how clots form. And I think it's worth showing everybody today because first and foremost, most of you know more than the residents and medical students that I teach about bleeding and clotting. So I want you all to know that this seems to us to be a more effective way to teach and help people understand the fact that when you form a clot or when you have bleeding, your body has three major components that help you form a clot. And most of you probably understand this by now, but one is that your blood vessel clamps down in areas of injury. So it starts trying to stop the blood flow to that area. And there are very important kind of special chemicals we call prostaglandins in the vessel wall that when there's damage, it triggers it just from a nerve standpoint to just close down. And that's true of particularly your artery and the arterial vessels. So they have this very strong stimulus, stop the blood flow. On the other side of the capillary, those little tiny blood vessels, the veins don't do that as much. And so this plays a role, vasoconstriction, more on the arterial side, but the veins can do it a little bit. So, but it's very, very important to help slow down the blood flow to that area. The next thing, most important thing that happens is that when the wall breaks down, like over here, collagen. Now, all you ladies that are out there, keeping your skin beautiful, no wrinkles, you know how important the collagen is to the integrity of your skin. And it's very important to the integrity of your blood vessels. So as soon as the blood vessel breaks open, the collagen and other things that we call in the subendothelial space that give tissue your strength are there, and they activate the platelets. So the collagen and the subendothelial proteins are revealed, and the platelets get activated, and they begin to form a clot. The platelet activation also stimulates the clotting proteins, right? So everybody in the audience has either a problem with their platelets or one aspect of their clotting proteins. So I'm going to focus on these two things right now. This other box down here talks about the clotting, the proteins that help slow down the blood clots. So your clots aren't too big. And that's a whole different lecture. And also controlling the size of the clot is something we call fibrinolysis. We'll get into that today. But a lot of people have defects or mutations in this area, and they're the people that have too many clots. And that can be just as dangerous and just as bad as a bleeding disorder in other ways. These two reactions result in either a platelet plug being formed, and it looks exactly like it sounds, and thrombin, which integrates the clotting proteins into the blood clot. One of the key things, just like collagen is real important for the factor, here is tissue factor. It is a clotting protein that is anchored in the wall and the tissue. It doesn't circulate around as much. There is some tissue factor in our circulation, but its main role is to trigger the formation of clot there locally. And what this looks like, and we sometimes think about, is the tissue factor binding with 7A to stimulate factor 10, the factor 8 and 9 forming a complex to stimulate factor 10. So you can see where factor 10 plays a really important role in clot formation. And then once the 10A is activated, once 10 gets activated, it forms with factor 5, hits prothrombin, and then thrombin is generated, and huge clots are formed at that point. What does that look like? Again, here's a breakdown in the blood vessel wall. Platelets start adhering, they activate. Activation brings in the clotting proteins, and red cells, platelets, proteins, white cells, everything gets tied up into the clot formation. Now, again, if you don't have the ability to stabilize your clot, or if you break it down too much, you can have little chunks of that clot go off and lodge in your lung. This is called a pulmonary embolism. And so it's very important to have the balance that we all need between these different proteins and ways of clotting. Here's what a platelet looks like when it first adheres. Immediately it starts sending out these little, what we call pseudopodia. The pseudopodia are basically anchoring. If you think of the ocean or a river flowing along, the platelets would roll like just would roll along if they couldn't anchor themselves to that site. So they have to send out these anchors immediately, right? Really fast, they have to send those out. And then they start spreading their cytoplasm in between those anchors until finally, this kind of looks like a ball of ice cream or a fried egg. Look at the area covered here versus the area covered here and ultimately here. Now the clotting proteins start forming on top of the protein. This is anchoring and just trying to fill in the gap, fill in the hole as quickly as possible. This takes just seconds to happen. It's truly miraculous. And in addition, with these anchors, there are little tiny muscles inside the platelet itself, so that eventually, once all the clotting proteins are intact on there, and once that mound of clot and cells and protein form, many of you know that would just kind of be like a big loose jelly. If you've ever had bad nosebleeds and you get these jelly-like, almost liver-looking clots, that's not a good clot. It doesn't work very well. There has to be something that causes clot, what we call clot retraction. That makes the clot really stable. It keeps it stuck onto the surface, and clot retraction occurs because of these little muscles in the platelet. And so what they do, it's like a fishnet. All of a sudden they retract. They retract after about 10, 15 minutes. When most of that gelatinous form is there, they retract, and then it becomes a good tight clot, more, and it starts to begin to look more like a scab, and it starts doing its job. It's not going to float away like that big gelatinous clot. So, isn't that miraculous, you guys? Just think about how all of that is orchestrated to form a good tight clot in the surface of your blood vessel. And I got to tell you, that's happening right now. All of us are just sitting here. That's happening in our body. We don't have to think about it. As long as we are trying to pull together all those pieces. Now, you may say, well, Dr. Nugent, I have factor 11 deficiency, I have factor 7, I have Glanzmann's. Yeah, you're right. Each of you, and myself included, we all have probably things in our clotting system that either predisposes to bleeding or predisposes to clotting. It's that balance that keeps us intact. And even though you may have a rare disorder, the reason I present all of this is that look at all the other ways that your body is attempting to form a clot. So if you have factor 7, which is a very serious deficiency, all the deficiency are really impactful, you more than likely have normal platelets. You more than likely have normal collagen. You more than likely have all these other pieces. This is what even people with bleeding disorders or clotting disorders actually do pretty well, because we have all this built-in backup for us. It's when you have a combination of disorders that it gets more and more challenging. And in our sequencing now, in the patients with the most severe bleeding defects, lo and behold, we're finding that people have combinations of defects. And that's why the sequencing is so important, and sequencing not just the deficiency that you have, but looking for deficiencies in other areas. And I'll talk about how we're doing that now, just to update everybody. And this is just to show you, this is what the break in a little capillary looks like. The platelets are starting to here, they're beginning to send out their pseudopodia. Here's platelets spread out in the blood vessel wall. Here's a little platelet plug. Here's what the red cells look like. But eventually, a very large clot, you can see strings of, this is a clot in the middle of formation. And they're going to capture some red cells. They'll even capture some white cells there. And then the clotting proteins come in. And when you have a little break and you don't have platelet number, let's say you have a very low platelet count, or if your platelets aren't working, instead of the platelet plug forming there quickly, it may take too long to form. And what happens is the red blood cells leak out. And so for people with platelet disorders or low platelet number, the hallmark for us is something called petechiae. And many of you may have seen these if you have a platelet disorder, these little, they're almost freckle-like lesions. And all they are is red blood cells that have slipped out of the blood vessel. Sometimes from pressure with excessive vomiting, for example, or women in labor, normal women in labor and so on, can have, just from blowing out their blood vessels, can have some of these petechiae. People on aspirin will see this if their platelets, if they're on too much aspirin or too many platelet inhibitors. But that's what a petechiae is, if you haven't seen it before. The platelets, as I said, besides adhering, which is what they're doing down here with these receptors to the collagen and von Willebrands, they also have the capacity to secrete substances that help with the clot formation. In particular, all of these receptors interact with thrombin. It's very, very powerful. The platelets have many, many ways that they can work. So again, the more common platelet disorder that we see is Glanzmann's, where they're missing this receptor right here. But on the other hand, and also that plays an important role in the Glanzmann's proteins in connecting with the clotting proteins. So that's why Glanzmann's is such a major platelet disorder. But we do have patients that are missing the collagen receptors. We have patients with abnormalities in each and every one of these. But for the most case, it's only one aspect of the platelets that's impacted, and those work pretty well. So that's what saves us really in the long run. So platelets really important. I wanted to get to the cascade on this. So let me finish this off by showing you that this purple substance here in the protein in the complex is tissue factor, and this pinkish protein is factor 7. Factor 7 is very common. I'm sure we have factor 7 deficient patients in the audience. This is very important because remember, once the tissue is damaged, the tissue factor is formed. So the first reaction, clotting protein reaction that occurs, is that factor 7 binds to tissue factor. It's the match that gets lit that triggers everything downstream. And this is why factor 7 deficiency is so common and so remarkable, is that if you have low levels, you are going to have some form of bleeding. This complex then stimulates the activation of factor 10, which triggers that very rapid progression to thrombin generation. So that's what this looks like. Tissue factor is revealed, 7 is formed, but complex. It stimulates the 10A, that very rapidly binding to factor 5 stimulates prothrombin to thrombin. Okay, so this is what we call the initiation phase. It's very important. I'm not going to put you through all of these different chemical steps, but just remember that tissue factor 7 really starts the whole activation phase going. Now, amplification, the building of the clot and getting more and more clotting proteins involved, that sort of it's very rapid expansion that occurs, what we call amplification, is mediated also by factor 7 at binding to tissue factor, and it brings in all the other clotting proteins. So here's factor 11, 9, 8. And what happens is that this begins to amplify over and over and over again. So trigger amplification, pretty soon more and more thrombin is being generated. That's stimulating the platelets. So just so you have an idea of how this works, one protein, as I mentioned before, one factor 7, factor 9, factor 10, 11, stimulates whatever its downstream protein is, it stimulates 1,000 of those. And each one of those stimulates 1,000 of its next downstream. So this one eventually begins to amplify and amplify the system. Each one of these green ones then in turn amplifies 1,000 more. So this reaction is what's going on in real life. And that's what you don't see in the PTT and the proton. You don't really see this amplification step. And yet it is so critically important. And this is why the most quantitatively, the large amount of protein that is in your bloodstream is fibrinogen. It's the bricks that eventually forms the clot. This is what is ultimately responsible for the clot that forms with the platelets and in the bloodstream. So if we didn't have some way of, and that thrombin generation, let me just say, that stimulates the fibrinogen, those little blue molecules at the end, in it and of itself wouldn't be enough if it weren't for factor 13, which is not captured in the proton or the PTT. Many people with factor 13 deficiency are told they're normal because their proton and PTT are normal. Well, yeah, it's normal because they're not part of that cascade. The factor 13 acts at the end to cross-link the fibrin and to stabilize it. And it helps, actually, you don't get that clot retraction unless you have factor 13. It stabilizes those little tiny muscles in each little platelet so that it can pull down and stabilize the clot. So that's where it becomes very, very important. And here we see factor 13 doing its thing. So it acts not just on the fibrinogen when you're forming a clot. And here's the clot. It's got all the red cells, the platelets, everything in it. It actually not only stabilizes fibrinogen, it cross-links factor 5, thrombus bond, fibrin. It stabilizes it in many ways. It also stabilizes the interaction of collagen and platelets together. As I said, it stabilizes the platelet cytoskeleton so clot retraction can occur. And just because it's an all-around good guy and ultimately fair, it ultimately also stabilizes the very enzymes that eventually are responsible for breaking down the clot. And that's important just so you don't have clots all over the place, but for healing. And without that, what we call tissue molding and modification, you don't heal well. You get big open scars. And in fact, people with factor 13 deficiency have problems with wound healing. Okay, so I hope that gives you a little bit better picture overall of how the platelets and the clotting protein components work together. Let me just carry on now with our talking about rare disorders. And so this talk is always a challenge for me because we have so many different moving parts. I'm not sure how many of you in the audience might have an abnormal fibrinogen, prothrombin. Here's factor 7, factor 8, factor 9. There are folks that have a combination of factor 5 and 8 deficiencies, 10, 11, and 13. this is not addressing what we do for platelets at the moment. But many of you with these deficiencies know that it's difficult to have a replacement that is just the protein that you're missing or is defective. Because it's rare, the companies haven't really made concentrates or purified concentrates of the protein that you're missing. And in particular, we prefer to use recombinant or genetically engineered proteins that we don't derive from plasma. But being we don't have that for many of our concentrates are derived from plasma, but they're heat treated, they're safe. We don't have the issues of HIV anymore, but we're always worried about what the next virus is. So as much as possible, your physicians and community organizations, if you're in a community-based family support system, we go to the pharmaceutical companies and say, can you please make a concentrate of purified fibrinogen, for example. And eventually, they were able to do that. I'm going to explain what non-replacement therapy is in a minute. Right now, we're just focusing on replacing the factor that's missing. And eventually, but if we didn't have that, we would use fresh frozen plasma. It's a blood bank product, or cryoprecipitate, where we pull out the cryoprecipitable proteins. That works for factor 13 deficiency and fibrinogen and von Willebrand's. But cryoprecipitate does not have the other clotting proteins. So for folks with factor 5 deficiency over here, all we have is fresh frozen plasma, right? So for a very long time with factor 7 deficiency, all we had was fresh frozen plasma. But eventually they formed a recombinant purified factor 7, but we can always get it. If we don't have that, we can always find it in a plasma-derived factor 7. We do have non-recombinant plasma-derived 7, and we also have FFP that we can use fresh frozen plasma. So going through here, there is something to treat all deficiencies, right? In some cases, like factor 13, there's both a recombinant factor 13 and a plasma-derived concentrate of factor 13, FFP, and cryoprecipitate. For factor 11, we really don't have a whole lot to use yet, just FFP. We're looking at plasma-derived concentrate of 10. It's not been approved in the United States, which is challenging for folks with factor 10 deficiency, but there are many clinical trials open. And sometimes we can get that with a special permission from the companies. So, sorry. Okay. The other thing is we can use some chemicals for factor 8 deficiency that include something called DDAVP. DDAVP is a substance that our body releases in the form of what we call vasopressin, and that will sometimes help us clot because it releases large amounts of von Willebrand's. So you say, well, why don't you just use von Willebrand's? Well, the nice thing about this was that it was available as a nasal spray, and patients could use it to prevent minor bleeding, like dental work, or nosebleeds if they were having nosebleeds. This was not available for a long time. It used to be called, it was available in a form called Stimate that was eventually taken off the market, and the company decided not to produce it anymore. A replacement DDAVP is now available. And if people are anxious to get that, you can usually get it through a special prescription through your HTC, Hemophilia Treatment Center. So you will be hearing more and more about that as time goes on. So this is where we replace with factor. Many of you who have deficiencies have probably received FFP, plasma, or concentrates, or even if you're in one of the lucky categories, have recombinant factor. Some patients, though, develop inhibitors to the treatment. Plasma-derived protein, because that protein is different from yours. Let's say you don't make factor 10. And so when we give you plasma that has factor 10, sometimes people see that as a foreign protein and they develop an antibody that keeps them from clotting. That's called an inhibitor. And so when that's the case, sometimes what we have to use are substances that are not the factor itself, not the replacement factor itself, but something that is actually used to slow down the clotting system. So let's think about that a minute. Remember all of those clotting proteins that got used up and rapidly burned up in the formation of clots? And I said, boy, if we didn't have a break, all of our body would be just one big clot. So there's something that actually reverses or slows down the clotting a little bit. What we found is that in people that are making an inhibitor, if we eliminate the brake, if we stop the brake from working and we let the rest of the clotting protein go ahead, even though they're missing that factor, in that case, it would be 10 I used, but for inhibitors in factor 8 or 9 patients, when we remove the brake, they're actually able to clot. And so even patients that we have with severe factor 9 deficiencies, severe form of hemophilia, and an inhibitor, we're now using these substances, they're here in red primarily, that actually remove the braking mechanism and people are able to clot. The reason we call this non-replacement therapy is it's not specific, right? So we can use this hypothetically on almost any of those clotting proteins in the clotting cascade. And now there are trials that are going on. People are saying, why aren't we using this in factor 10 deficiency? If these are working, why can't we use it in other instances? Maybe they'll even work for people with platelet disorders. We haven't tried that yet. The only reason, if you have a rare disorder, that you haven't seen us trying this yet is probably because it is in trial status. So just for those of you who are still waiting for something specific for your deficiency, it may be that we end up going to the non-replacement therapies first. Okay. So we often talk to folks, doctors and patients about bleeding scores, and that helps us understand how much bleeding you're having, how severe it is. Epistaxis is nosebleeds, cutaneous means skin bleeding, bruising. If you have a minor cut or wound, how much do you bleed? Here's oral, dental bleeding, GI bleeding, bleeding in the gut, and down here, actual tooth extraction. So as the scores go up, either -1, 0, 1, 2, 3, 4, you have more bleeding the higher your score. So some people can have tooth extraction or their tonsils removed and they have no bleeding at all. You actually get a minus for that. It's like, wow, really unlikely that you have a major bleeding problem if you can get through that. But for the rest of the scores, it may be that you don't have bleeding with any of these, maybe a little bit of bleeding, trivial bleeding. So we give that a 0. As the bleeding intensity goes up, maybe you are commonly have petechiae or bruising. Maybe actually when you have a nosebleed shunt or your nose packed, or even worse, you bleed so much you need to have a blood transfusion. So this is called a bleeding score, and we grade for each and every one of those. And if you have a high bleeding score, it helps us understand the severity of your disease. And so here's an example of people with a very, very low von Willebrand's, in particular type 3 von Willebrand's, where they have no von Willebrand's at all, and they have a very, very high bleeding score. The von Willebrand's variants kind of fall in between. Type 1, which is the most common von Willebrand's, sometimes we see bleeding, sometimes not. So we're able to really get a better sense of the bleeding score. Well, you've probably been asked or had that score performed for you. It's an important thing to help your doctors understand the likelihood of your bleeding. For young women, it helps with deciding whether patients should go on birth control to help control their bleeding, or how much support we need to give after delivery. For every patient with a bleeding disorder, particularly women that have heavy periods, you need to monitor the iron. Because if you remember, the red blood cells play an important role in clot formation. We can't leave them out. And in addition, of course, staying on a healthy diet, vitamin C and vitamin K are really, really important to help with bleeding. So many women are on hormonal suppression or birth controls to limit the amount of periods that they have in order that they don't become severely anemic. Okay, what is the distribution if you're a rare disorder in general? We know that the factor 7 patients and factor 11 tend to dominate, and that's still true, even though we're doing a better job of picking up some of the other deficiencies. Factor 13 up here is about 7%, fibrinogen 8, and you can see and look for your own. There's factor 10 over here. The combination of 5 and 8 is a little bit less common. And these percentages, relatively speaking, haven't changed. Janet asked me to be sure and comment and show that the work that's been done by all of you. Many of you have made your blood available for sequencing your particular protein. That was initiated by the CHESS programs where we did 210 patients. We did many more family members as well. So we have probably close to 400 or 500 total from the number of CHESS patients and family members, but patients themselves, 210. And with the AFN sequencing, we've done 485 now as of last month. So now in the United States, we have sequenced through those two programs close to 700 patients. And what I'd like to point out is that when we're doing the sequencing on our new panel now, which measures 30 genes simultaneously, is that when we look for, let's say, CHESS sends us patients that have factor 7, we find factor 7, but in a certain percentage of those, we also see that we find a fairly large, close to 20% are actually, excuse me, not 20%. 20% of the patients have multiple gene abnormalities. And those are in particular the genes that are more severe, the patients with the higher bleeding score. We usually find that there's more than one variant impacted. About a very small number, about 4%, when we sequence, we don't find any abnormality. Sometimes those patients actually have inhibitors, they don't have deficiencies. And then in a very large number of patients, we see new genes that have never, new variants, new mutations that have never been described before. This is the breakdown of the patients that we've done. Here's the factor 7s, fibrinogen, Glanzmann's, and then all the rest. So factor 13 is also very common among this group. This is just an example of all the new variants for anybody who's a geneticist in the audience. It's just pretty amazing that we're finding so many new genes that haven't previously been, new variants or mutations that haven't been described. So one very important thing that we also ask and teach our residents is, what are the signs and symptoms of someone with an underlying bleeding disorder? And I think that you can see here, nosebleeds really are very important. Easy bruising, gum bleeds, stomach, intestine, blood in the urine, brain bleeds, very serious, fortunately not as common in the overall population, and then heavy periods for women. How symptomatic are patients? Well, you know, this is an example of factor 7 deficiency. Factor 7 deficiency patients, sometimes we pick up factor 7 deficiency and half of the patients are not symptomatic at all. And we believe in that setting, either they have a variant that just lowers the level, but in general, they make enough to control their bleeding, or they sometimes have another mutation that helps them clot faster. So just like we use in non-replacement therapy proteins to help control bleeding, some people are just born with lower levels of the braking mechanism, and so that helps them compensate, and they don't have as much bleeding in that setting. Some patients have bleeding only after trauma. 20% of factor 7 patients have spontaneous bleeding and really abnormal menstrual periods, and about 7% present with major bleeds requiring transfusion. So there's a spectrum, and that's where the bleeding score is important. So here's factor 7 again, but now you know and understand this reaction much better. We've gone over that. This is what the tissue factor looks like. I use this as an example of showing where we find mutations in the factor 7 molecule. And you can see all of these mutations cause a problem with the factor 7 actually binding to the tissue factor. And when we find no mutations in the factor 7, one of the things that our lab is doing research on now is saying, well, maybe there's mutations in tissue factor, because it's much more difficult to isolate tissue factor, but we're going to start sequencing that as well, because that may explain some of the negative workups that we're getting. So if there's a defect in the tissue factor, the factor 7 is not going to bind either. So this should look, I want to point out that down here, these are sites on the factor 7 where vitamin K does the final step to make factor 7 actually be able to function. If vitamin K does not add these what we call Fla residues where the calcium can bind, then the factor 7 can't work. Factor 7, 10, 2, these are the vitamin K dependent factors, 9, and they, if they don't have that conversion, they can't bind calcium, and so clotting will not occur. Vitamin K is very important, so please keep up with your vitamin K. I mentioned before that tissue factor inhibitor breaking, if we eliminate this, that patients speed up their ability to clot. This tissue factor pathway inhibitor acts very, very early on and plays a major role with factor 10. So I just wanted to give you a little picture of that. People with tissue factor inhibitor deficiencies, they clot too much. So that's the pathway there. You are actually showed you that. You've seen this. I'm going to speed it up a little bit. Now, when we look at the new frontiers in rare bleeding disorder diagnosis, we have really jumped into the genetic approach, because all of us have lots and lots of gene mutations, normal or with rare disorders, and it's that balance between bleeding and clotting that makes a difference whether we have a really high bleeding score or not. So the genetic variation is very important to us, and that's why when you're asked to do that bleeding score history, it helps us understand if we find a variant or a mutation, is this a serious mutation or is it not? We match that with your bleeding score and your bleeding history. So this is factor 7. This next little bit is going to be all about factor 7. So I don't want everybody else to fall asleep, but pay attention for the factor 7 folks in the audience. We've done a lot of work on factor 7. This is the molecule. It's from beginning to the end. And if you see, one of the important things about all clotting proteins is that they have multiple jobs. They have different areas that they cleave other proteins. Here's the vitamin K dependent domain. This is where it binds to tissue factor. Here's where it cleaves or activates 10A. So all of these different sites play an important role. This part up here in the beginning is what controls the levels of factor 7 that are produced. And so we found a lot of genes that are important just for the factor levels. This is what the gene itself looks like. It gets coded. These are called exons. These are the part that ultimately end up in the protein. But the gene itself has large regions between each part that becomes the ultimate protein that are called introns. We used to think this was junk DNA, but in fact, it's very, very important. And these splice sites where the arrows are, if you have a gene variation there, sometimes what happens if you have an abnormal splice site, only this portion of the protein comes together and all the rest of this is missing. So we look for those, we look for splice site abnormalities, we look for nonsense mutations that results in the protein not working very well. We also look for large deletions in the proteins. And then if an amino acid or if there's a mutation that occurs, in fact, it can change the whole order of the whole read of the DNA. And then you get a protein that doesn't do what it's supposed to do because it doesn't have the right sequence. So there are many, many areas where we see protein mutations or changes due to the underlying DNA mutation. I've color-coded these. Here's the vitamin K variants or mutations that we found. These are listing all of the common mutations that we see that result in changes in, this is the enzyme portion, this is the part that binds to the tissue factor, and this is the part that's important for vitamin K. If you have a variant up here, you don't even code the protein. So this results in no protein at all being produced, as well as this cleavage site here. So why is it color coded? Because if we actually do the bleeding score for each of these areas, we find that these folks have very severe bleeding. In this group, sometimes this is the group that ends up in 50% sometimes aren't even symptomatic. You don't even see any bleeding because there's so many other sites, enzymatic sites that work. So in doing the bleeding score for people who have abnormalities here, they can't find a tissue factor, they also have very severe bleeding. So this is why knowing what your sequence is helps predict what your bleeding pattern will be. So we think it's really important if you're diagnosed, for example, with factor 7, to have the sequencing done, and it'll help you understand a little bit more about the pattern and type of bleeding you have. We talked about a number of ones that we found out. So here's a different look at the inside of the vessel. Here's tissue factor, factor 7, binding and activating 10. We have revelation of the tissue below the blood vessel, and so the platelets are forming this clot, and the fibrinogen then starts accumulating thanks to thrombin activation of the fibrinogen. Fibrin is formed, and it begins to form that fishnet within the clot that it's so important. Now, nutritional factors, I've mentioned vitamin K, vitamin C are important, but a lot of the food we eat have natural medicinal qualities themselves. We give vitamin K to children when they're born because they have a tendency to get what we call hemorrhagic disease when they're born. It is because they're missing or have low levels of these factors just because they're not getting exposed to vitamin K in utero. Just this year, we had a family that just thought having a small shot of vitamin K at birth might be a problem, and came in with a massive intracranial hemorrhage. And this is why we really recommend vitamin K shot in the beginning. If families refuse to have that shot, we do ask them please to start supplementing with vitamin K orally. It's very important. Liver failure. Liver is where all your clotting proteins are produced, the majority of them. Not von Willebrand's is produced in the vessel, but pretty much all the other proteins are made in the liver. So take good care of your liver. Don't drink too much. Don't expose it to things that are toxic. One of the ways that people injure their liver inadvertently is by constantly taking Tylenol and Advil. That has a really major impact on your liver and can cause long-term damage. Vitamin C deficiency will cause bleeding and actually scurvy, which we think of as in the old Columbus days, the sailors that were out in their ships forever had no exposure to vitamin C. They did used to take little small lemon trees and lime trees on the ships. Even then, they knew that there would be a problem if they didn't get some sort of citrus exposure. And that's why a lot of the old sailors are called limeys. You may have heard that. And if they just got a little vitamin C through those plants that they took with them, it would help prevent scurvy. Scurvy or severe vitamin C deficiency, though, will cause mouth bleeding, gum bleeding, a lot of bruising, and other problems. We do see a lot of antiplatelet effect from garlic, raw garlic in particular, ginseng, and ginger. So when we have people in our lab serve as the normal control for platelet aggregation studies, we'll know right away if they went out and had a big Middle Eastern or Italian dinner with a lot of garlic exposure, particularly hummus that has raw garlic in it, or sushi with the raw ginger. We can see that absolutely the next day on their platelet studies. And people say, well, I didn't eat that much. These are very powerful, and it's why that garlic is available commercially, because it will cause the platelets to be less sticky. And after menopause for women and for for men at high risk of heart disease, we actually recommend garlic in lieu of aspirin for people who are aspirin resistant. It does have a really, all of those things have a major effect on platelet function. The other one, which we had an epidemic of here a few years ago, is fish oils and the omega-3s. Again, what you're looking at are all the components of a great Italian, Mediterranean diet, which is so healthy for your heart and for your blood vessels. And that's because the platelets are mildly affected and cause less clotting and less vascular disease. There was a time when people thought the omegas were really important for brain health, and a lot of parents started giving their children fish oil and in their diet, and we had an epidemic of bruising and bleeding in children, and we realized it was from all the fish oil. The Eskimos that eat a lot of blubber and get a lot of exposure to omegas actually have severe nosebleeds. It's a very common, we've recognized that in the Eskimo population for a long time. So if you have an underlying bleeding disorder, I'm not saying you should have no garlic or ginger or ginseng fish oil. These are what make life meaningful, obviously, but just don't overdo it, and keep track of when you have them. Obviously, there are a ton of medications that can cause abnormalities in your bleeding and clotting system, particularly the impact on aspirin. People don't realize that Midol and Alka-Seltzer, you got to watch out. They have aspirin in them. Pepto-Bismol, the bismuth, causes platelet dysfunction. Serotonin inhibitors are antidepressants. So please screen with your doctor if you have a bleeding disorder. Let them know, because these can tend to give you more bleeding. Certain antibiotics, and then will also cause platelet dysfunction, and the penicillins in particular, and then vitamin K. Okay, so if you guys handled that well, this is kind of a little bit of a point where I try and stop and ask if there are any questions.
Is it possible that even with severe GT, 100% missing the protein, upstream bits might decrease the amount of bleeding?
I think yes. So I'm on some advisory boards where we're talking about using one of those two drugs in patients with GT to see if it helps. Because GT, for folks in the audience that don't know, stands for Glanzmann's thrombasthenia. It's a really severe platelet disorder when you're missing the proteins, as the person in the audience asking the question infers. It can be just incessant nosebleeds, incessant bleeding, really severe problems. And, we brought this up. We're seeing almost miraculous results in doing it for severe factor IX deficiency with inhibitors. We go, can we not at least try this in Glanzmann's? Because in theory, it might work. And although it might not stop all bleeding, it might really make what's there less. And so, we know that Amicar works to a certain degree in Glanzmann's because it stops the clot from breaking down, right? Why not remove the breaking mechanism as well and see if we can make it clot? So I am a pro, let's give it a try fan. I'm hoping if there's a study open and someone in the audience knows about, let me know, because we've really wanted to be part of that study for our Glanzmann's patients where the bleeding is so severe. So yes, I think it could work with Glanzmann's. I don't have any data.
Thank you. Another GT question, which factors are missing in Glanzmann's thrombasthenia?
The glycoprotein 2B, which is one of the structural proteins on the surface of the protein. I think I might have another picture coming up, of the platelet. But the reason it's important is it's not only important for adhering, but it's really important for binding the fibrinogen that makes it part of the clot. And so the glycoprotein 2B and glycoprotein 3A are the two proteins that sit together on the surface. Sometimes you're just missing one. That means the receptor doesn't work. Sometimes you're missing the other. Sometimes the one that you're missing is responsible for getting the receptor up on the surface. But there are families that have no protein. Yeah, they've inherited a deficiency from each side of the family, and that can be very, very severe bleeding. So I'm gung ho. I'd like to give it a try. So this is to launch into the next part and to get more specific about the clotting proteins themselves. I'm sorry to be a little redundant, but I think if you look at this in these from different aspects, some people see the clotting cascade better one way or the other, and it's really important to understand how this works. So if this little green thing here is a platelet, I think you've learned the fact that here subendothelial is exposed, the collagen, here is this blue twiny protein here that's revealed. The platelet sticks to that. Here is actually, see this is actually one of the integrins, which the 2B3A molecule is part of the integrin family. They begin to stick, and as the platelet is now going through its shape change, remember it starts sending out those pseudopodia, it starts activating the platelet surface. Now that integrin becomes activated itself. So it starts binding to the fibrinogen, this little fibrinogen molecule here. Now we're starting to form the platelet plug. The integrins, or the things that adhere and stop the platelets from moving, are bound. These are collagen receptors and integrins. This little purple thing here is fibrinogen. It's getting more and more incorporated into the clot. Now more platelets are being called in. So here's an unactivated platelet, but it's getting pulled into the platelet plug, and it starts bringing in, through von Willebrand's factor here, more platelets. So now the plug is aggregating, thrombin is being generated. Once thrombin is being generated from this activity, you start getting factor 9, and here's prothrombin. They start getting some energy from our little buddy, the red cell. And the reason this is an important thing, again, for you all to get a good take-home message is if you are anemic, if your hemoglobin is less than 10, you don't have as many red cells as you need to participate in clot formation. I think we've done a poor job at helping people understand that the red cell plays a role in clot formation as well. Not just because they add a viscosity or a thickness to the blood, right? If you think about it, when you're anemic, your blood is more watery. And when you have a normal number of cells, it's just thicker. And that thickness and the phospholipid and the membrane itself plays a really important role in that amplification of a clot. Remember, there's the initiation and then there's the amplification. So now factor 5, factor 8, 9, 10 are getting involved. Here's factor 12, which, remember, it's sitting down there thinking, oh my God, I've got to clean this clot up eventually. But it's sitting there on the surface. Factor 11. Now, factor 11 is actually a fairly common protein, clotting protein deficiency. And although the bleeding is maybe not as excessive as further down in the cascade, it interacts with platelets, it interacts with the subendothelium. It actually is a multi-purpose protein. So I think in this particular diagram, it gets short shrift, but it is playing a role to help get the clotting proteins all activated and involved with the process of forming a tight, what I like to call the terminal plug, one that's going to retract, one that has a good fibrinogen level. Here's the fibrin, which is forming that fishnet integrated throughout the clot that eventually retraction is going to occur. So the red cells actually do get incorporated in the clot and play a really important role in providing energy in the form of ADP, as well as phospholipid service. So again, just want to reinforce that message. All the clotting proteins, all the platelets, everybody has a role in the process. Now, here is an example of the factor 11 molecule. And if there are factor 11 individuals there, I am guessing that you are primarily women. Women are picked up as having factor 11 deficiency, usually because of their heavy periods. it becomes a problem later with childbirth because anesthesiologists, when they see the PTT and someone with factor 11, see a very long PTT, because remember, it's up high in the cascade. So any deficiency that's high in the cascade is going to have the largest impact. It's going to slow that process down in vitro in the lab. But in fact, the bleeding for severe factor 11 is really only present if the protein is not made at all. The more typical finding that we have in sequencing factor 11 patients now is we'll find an isolated variant in one portion of the molecule. So here's a good example. Over here, this is factor 9. We know that there's an interaction of factor 11 with factor 9 in clot formation, and it's impacted when any one of these amino acids is mutated or deficient. But we don't see major bleeding. Sometimes we'll see a little bit more if there's a variant over in just a little bit further in the molecule, because this is where it reacts more with the platelet to glycoprotein 1b. There's a very strong interaction. So this is a factor 11 platelet interaction. This is a factor 11 factor 9. We see much more problem if we find a variant in the thrombin portion of this molecule. This is where thrombin interacts with factor 11 as far as activation. Then this molecule is quite a bit more dysfunctional. The catalytic domain is also an area where if we find variants in this portion, there can be problems with the function. My point here, and I'll just say for those of you that are looking at factor 11 and thinking, oh my gosh, what a crazy molecule. These are called apple domains. You can see why, right? They kind of look like upside down apples. And each one of these has a different role, a different function. This is a highly evolved molecule. So if you have factor 11 deficiency, just know you have one of the highly evolved molecules. Somehow it feels a little bit better. But you can see where a lot of the clotting, and this is true, most of the clotting proteins, they have more than one job. And this is why some people with factor 11 have bleeding. It's pretty significant and severe. Other people, they may have a low level, but it's just as a result of a variant in a minor minor activity of the protein. And so its impact is not so great. And so fortunately, factor 11, although many people have it, it's not as severe a bleeding disorder as some of the other ones, but it can be. So it's an example of the variation that you see with each of these. This is just another way of looking at the rare disorders. This is factor 13, and it shows that from country to country, right, there's different frequencies. And what we're discovering, we used to think there were only 106 patients with factor 13. We've sequenced close to 300 now. So I think now that we're beginning to know how to look and how to diagnose this, all of these numbers are going to grow. And so I just mention this because we're probably not only underdiagnosing factor 13, but all of the rare clotting proteins, but we're getting better. So there's hope. Factor 13 now is another molecule that I just want to mention to everyone. It has the same kind of bleeding, nosebleeds, mouth bleeds, bleedings in the GI tract that other bleeding disorders have, but they also have some very unique bleeding. And one of them is bleeding of the umbilical cord at birth. 90% of the children with factor 13 deficiency bleed in the umbilical cord. That's almost diagnostic of factor 13. We drill this into residents, medical students, because if you can diagnose it from umbilical cord bleeding, you can prevent the risk of the much more serious complication with factor 13, which is present in 30% of the patients, usually within the first 5 years of life. And that is massive bleeding in the head. And people they can get severe intracranial bleeding, which results in lifelong disability. So we emphasize over and over again that if you have a baby with a bleeding umbilical cord, it's factor 13 until proven otherwise, and get them treated because you can prevent the death. But really, there's a lot of different manifestations of bleeding and factor 13 deficiency. And what we realize now that there are probably many more people with mild factor 13 deficiency than we appreciated. And I'll tell you why in a minute. Again, I mentioned that 20% of them have really severe wound healing problems or tissue healing, heavy periods, which is what menorrhagia stands for. But another unique feature of factor 13 is miscarriage. Women with factor 13 deficiency have a lot of difficulty carrying their pregnancies past about the second month of the first trimester of pregnancy. So for a woman with recurrent miscarriages, we always try and diagnose factor 13 if it's present. Intracranial hemorrhage, as I mentioned, is the thing that we most want to avoid, and why it's so much more frequent in factor 13 as compared to even severe hemophilia. We see spontaneous bleeding in factor 13. So we know it must play a very important role in brain development. So, and vascular integrity repair. I tell all the residents and fellows, if you want to really make a name for yourself, figure out why that's happening, because we still don't understand the role of factor 13 in the brain. Now, factor 13 has a few other unique features, and that is that it's not just one protein. It has 2 A subunits and 2 B subunits. And you can inherit the sequence for one of the A subunits from one parent and maybe have another A subunit from the other. But these proteins, whether they're both from your mom or both from your dad, same is true for what we call the B subunits. These are produced in the liver. The A subunits are produced in the monocytes in the bone marrow. We know this because, and here's a better example, there's also a ton of the A subunit in the placenta, and internally in the platelets. There's the intracellular form of factor 13, which are the 2 A subunits. And then in circulation, you have the 2 A subunits with the B subunits. So we've always thought of the B subunits as just carrier proteins that prevents the A's from being broken down. But we've also now learned that it's the B subunits that get it to a site where there's tissue damage and bind to the fibrinogen. So factor 13 is a little more complicated, and you can have a variant or a mutation in the A subunit and have perfectly normal B subunits, and vice versa. Here is again a good example of the A subunits are made in the megakaryocytes and monocytes, and the liver secretes the B subunits. So the A comes out into circulation and it almost immediately binds to the B subunits. And that's the way we find it in circulation. How do we know this? Because we've done bone marrow transplant and found that the genetic sequence of the A subunits switches to the donor bone marrow. And the same is true for liver transplant. So in circulation, thrombin activates the molecule. So the activation peptides, which keep this in a calm state, disappear. The B subunits get it over to where it needs to be for the fibrinogen. The A subunits have what we call the catalytic portion or the enzymatic portion of the protein that does the actual cross-linking of the fibrin and all those other proteins we talked about that it stabilizes by cross-linking proteins, keeping them so they're bound to each other and stabilized and more difficult to break down. And when we look at patients, the majority of patients that are diagnosed are missing that A subunit, because if you don't have the action part of this enzyme, you are going to have unstable clots that break down really easily. And if we do look at just the protein levels, the A subunit in patients, here's the normal level that we find. Here's some people with mild factor 13, and then there are many people that are missing the A subunit altogether, and they have very severe bleeding. One of the things we found out right away in our lab is that we were working as a research lab showing the impact, what the survival, we were doing pharmacokinetics of the new recombinant factor 13. And the new recombinant factor 13 only has the A2 subunit. So it's factor 13 A2. And so when we infuse that into deficient patients, it bound to their intrinsic B, because they were making B, but they just had no A. And what we found is, here's the survival. This is 1 month. We had a really pretty decent half-life, somewhere between 10 and 14 days. And we had all these different ranges of dosing that we were trying. It was looking good. And all of a sudden we had this patient show up. And they had a really good infusion. We infused it, it went up high. And then by 24 hours, it was less than 20%. Oh, we had, what the heck is going on with this guy? Eventually, what we figured out was they were missing the B subunit. They were not A subunit deficient. But this is what happens if you don't have any B subunit, is that the B is really important for the A to survive in circulation. So you can have factor 13 deficiency, not because you're having an A subunit mutation or variant, but because you're missing your B subunit. So now, so would this recombinant A2 subunit product work? Well, yeah, it works great for these guys, but if you're B subunit deficient, you have to use the plasma-derived factor if you want to have a normal factor 13 survival. But for B subunit deficiency, even the plasma-derived factor has a shortened half-life because it's just not as stable in circulation. So knowing whether you're A subunit deficient or B subunit deficient is a very, very important thing. And platelet interactions with factor 13 are really key. We talked about how the intra-cytoplasma factor 13 is responsible for clot retraction. And that's what we're trying to show here. Here's a very fancy cross-linked protein, fibrin molecule. It's really important that this cross-linking occurs to stabilize the protein. But here, that 2B3A molecule that we talked about with Glanzmann's, it's bound to the fibrinogen, but without the factor 13, it will not clot retract. And also, of course, if you don't have 2B3A, you don't have any interaction at all with the fibrinogen, right? So this is, again, how all the systems really work with each other. What we also, yeah. Yes.
I'm sorry. We could probably listen to you all afternoon, but I just want to make certain that we've got about 5 minutes left and we do have some questions. I know.
Okay.
It always goes by so fast.
That's okay. But I think we got to the main points. I was just saying that this is another way we can look at clot. So I'll come on.
Thank
so
you.
all
right.
No
I've got some hands raised here.
Let's do it.
Cami, I'll work this way.
I am missing totally all collagen and I'm markedly decreased in.
Yeah, I was going to say you are, and I thank you for sharing your story. It was kind of hard to hear. Did you say your primary factor 7 deficiency? Was that the primary or?
Collagen deficiency.
Oh, collagen. So you have one of the collagen tissue defects. So
I'm diagnosed.
Ehlers-Danlos or one of those.
I have dense body, storage pool disease,
Okay.
platelet defect. I'm totally absent in collagen, and I'm markedly decreased in DDA and rhizocetin. I have
on your aggregations. I got it. Okay.
I have an aggregate release defect and a clotting defect. And
yes.
When we tried factor 8 and DVP, I have no response, and my only treatment is platelets. But when I've had surgery and I had platelets donated less than 24 hours before, I still hemorrhaged in surgery, and they made the hematologist come into the operating room, and they only did half the surgery. Now I need to have some spinal surgery, and nobody even wants to look at me.
Yeah, this is really challenging. And let me just say, to add to that, which you may be able to share with us, is that people with the kind of platelet disorder that you have also have a lot of problems, not just with controlling the bleeding during the surgery, but with healing long term. And what we end up having to do with our patients with your particular defect when they've had surgery is not only cover them for the surgery, and I heard you say that it's not working for you even for the surgery, but if, let's say we figure out a way for you to get the surgery, and we can talk offline, because I know that
Thank
this
you.
is more complicated maybe than you need to know. But you have to have continued platelet infusions until you're healed. Otherwise, it is not going to work. And I would look, did they look at your, we can talk about it, but they should probably look at your factor 13 as well. So, but let's talk offline.
Thank you.
And maybe you could give her my my email address, which
Thank
is my
you.
name, Diane Nugent, the number 7 at Gmail, and everybody is welcome to pile on. So what's some other questions?
Thank you. All right, I've got time for a couple more.
So I've been having a lot of bleeding issues where I'm passing a lot of blood clots. So my hematologist does not want me to use factor, but my gynecologist wants me to use factor because she's like, that would help. But the issue is the clot, even if I do use factor, it doesn't help. And then my gynecologist, she wants me to take birth control on top of the one that I already have. I don't know where to go.
Do you mind sharing what your deficiency is?
Oh, factor 7.
Okay, great. So I have to say I'm a pro factor 7 person. So I do think factor helps, but have you tried Lystida? Are you using Lystida during your periods? It doesn't help. Okay. And so, heavy periods also predispose you to iron deficiency. Are you having a lot of anemia as well?
So my iron level is 34, and according to my illness is low on it. So my doctors, I've taken all the supplements that are available on iron, but they said that continue to take it, but it's not changing years after years. It's not changing the levels at all.
So for somebody in your situation where the usual things we use just don't help, factor support, Lystida, hormonal suppression is what we recommend, and it doesn't necessarily have to be the classic birth control pill type approach. Some people also use, now they have much better IUDs that are embedded with hormone to suppress your periods just locally, so you don't have the systemic effects of a birth control pill. So a lot of options for women with heavy periods. The good news is you're not bleeding from a whole lot of other places, so that if we can control your periods, and as I said, there are many approaches to hormonal suppression, either locally or systemically. But having heavy periods is very, very difficult for women. It keeps them from normal activities. You tend to work your whole life around when you're going to have your period. You can become, it can be very depressing. You can get anemic. So we work very, very hard. And we have a women's clinic within our center at the Center for Inherited Blood Disorders. It's called SWAG. I think it's a great name. It's run by 2 of our hematologists and OBGYN. We work very hard to make sure that the periods don't interrupt with the quality of your life. And so I think long-term, it's a really important thing to get those periods under control. So again, you got my email. I'm happy to talk more about it.
Thank you. All right, we've got time for one more, and then I will circulate a piece of paper that we can write down questions, and I will send them to Dr. Nugent. I'm sorry, there's never, ever enough time for this session. Aida.
Okay, in this case, I'm going to keep the question very simple and short. In individuals where they have 2 different factor deficiencies, therapeutically, what should they target in terms of bleeding, or if they have surgeries? Do they target one that's upstream or downstream, or both?
We do both. If we have treatment for the, so we find factor 7 patients with factor 13 deficiency, we treat both. We have a lot of patients that were diagnosed with platelet disorders that have factor 7 deficiency, or have factor 13 or factor 11. And if they're going in for surgery, we make sure that both of those are normal, and especially or any other kind of, like heavy menorrhagia. Why not, if we have the ability to correct each one and normalize people, why don't we do it? And I think it's been a big breakthrough in our clinic. there's a tendency for doctors to say, oh, here's factor 7, we're going to treat that. And you think, well, you know, and if the bleeding's still going on or heavy, you just keep trying to adjust that factor 7 dose. And in fact, we should be looking at the involvement of platelets. Be sure and check the von Willebrand's, look at all the other rare disorders, because in a family where one thing rare has happened, to be honest, we're finding somewhere around 10% have a second rare. So it's always good to look, always good to look. I'm sorry I'm not there to stay and talk during the break. And,
Thank you.
but
Can I do one last question? There was a question about bone marrow transplants for Glanzmann's thrombasthenia. Could you just talk, and we know.
Yeah. So we've done that. We, you know, the balance with, you know, a lot of people are familiar with bone marrow transplant for cancer. And in that setting, you're doing a bone marrow transplant because there is no other option. You're full on chemotherapy. It's really life-threatening. In the case of a disorder where you have some treatment. So for Glanzmann's, we're using Nova-7, we use Amicar and so on. We kind of, we tend not to just jump into bone marrow transplant no matter what. But when there is a perfect match in the family and the child is young, which is the best time, earlier the better for bone marrow transplant. Although I've transplanted patients up to their early 20s. If you have a good match, you are less likely to have one of the side effects of bone marrow transplant is something called GVH. We really don't see bad GVH anymore. We've got great treatment for that. But if you have a perfect match, that's usually not an issue. Many patients with Glanzmann's develop antibodies to platelet transfusion, so they become resistant. I've transplanted patients through that because the treatment we use for the transplant also eliminates the antibodies. We've been able to do that without any problem. Patients, once they have normal platelets, or if they're getting it from a family member, they may be getting from a carrier, but the carrier doesn't bleed. So if you go from having severe Glanzmann to being a carrier and just bleeding a little, it's still okay. The big concern I have is that we get some patients that hit menorrhagia, that hit their periods, and it really gets serious. People almost bleed to death from their periods, and we have to be able to, for the most severe patients, the patients with Glanzmann's, where controlling the bleeding is really difficult. I feel very strongly that bone marrow transplant is an option until we get better at gene therapy. I'm a big believer in gene therapy, and we're totally gearing up to do that in our center for the hemophilias and where gene therapy is available. But you know, for Glanzmann's, you have 2 abnormal proteins, so you're going to have to do gene therapy on both. There's some other approaches, injecting the gene for other factors in the platelets. We're trying to make artificial platelets that aren't immunogenic anymore. So we still have some treatment options for Glanzmann's, but to really live a normal life, transplantation is what we do. And I think that we hold back on transplant if there's not a good match, because if it's not a good match, then you're buying a lot of other problems. So, but if you had a perfect family relative match, in a child that's exhibiting that they're going to be severe, then we do it. I've probably done 10 transplants for Glanzmann's, and
Wow.
they've gone well.
Thank you, Dr. Nugent, for your time, for your expertise, and your commitment.
Love you guys.
Thank you. Thank you, everybody. Bye-bye.
Bye-bye.